Hello, my name is Marlise Luskin. I'm a physician at Dana-Farber Cancer Institute in Boston, Massachusetts. I'm an assistant professor at Harvard Medical School. I'm really pleased that the ALL Hub has given me a chance to tell you a little bit about a presentation from our group that was at ASH just a few days ago. On December 7th, we presented an abstract entitled "The Rate of Orthopedic Toxicities in Young Adults Treated on Dana-Farber Cancer Institute ALL Consortium Trials." What I'd like to do in the next minute or two is just tell you a summary of what we found. So the group of patients that we studied are young adults, so adolescents and young adults, who are receiving pediatric-inspired ALL protocols. And why are they receiving these treatments? It's because there was a recognition over the last few years that young adults treated on pediatric-inspired protocols have better outcomes than when treated on traditional adult protocols. And this has really improved the survival of this patient population and has been a major advance in the treatment of young adults with ALL. A major component in these pediatric-inspired protocols, including the Dana-Farber Consortium ALL protocols, are the inclusion of many doses, heavy use of a drug called asparaginase. And asparaginase, while a very effective drug for ALL and a major reason for the improvement in outcomes in patients treated on these protocols, has a lot of unique toxicities that require careful management. There's been a lot published about these toxicities, including the effect on coagulation, risk of thrombosis and bleeding, pancreatic toxicities, hepatic toxicity, metabolic syndrome. But a relatively less studied or less understood toxicity is the impact on bone health, specifically bone toxicity, given the fact that these toxicities tend to occur late in therapy and are often under-ascertained and understudied. So what we set out to do was to review all the patients aged 15 to 50 treated on or as per Dana-Farber ALL Consortium protocols. So these are all adolescents and young adults treated on pediatric-inspired Dana-Farber protocols over the last 20 years. We attempted to ascertain the rate of orthopedic toxicity, specifically the occurrence of osteonecrosis and fracture in these patients, and understand the risk factors for these events. And what we found was that there was quite a high risk of or osteonecrosis and fracture in these patients. Almost 20%, 17% of patients had an osteonecrosis event by 5 years, and 12% had a fracture event. The median time to these events were about 1.5 years, so these were late occurrences. Many of them occurred after the completion of therapy when they weren't seeing their oncologist as often. And a number of these events, almost half, required surgical intervention. When we look more deeply at our patients to figure out who was most at risk for developing these events, we found that older patients, we found that younger patients under age 30 were more likely to have an osteonecrosis or a bone event. And we saw that patients treated on later generation protocols that used a newer pegylated form of asparaginase were more likely to have toxicity than patients treated on earlier protocols that had a shorter acting version of asparaginase called E. coli asparaginase. And our hypothesis is that asparaginase that is pegylated has a longer half-life and leads to decreased clearance of dexamethasone, or a steroid that is also a component of these regimens, and that this higher exposure to steroids via the pharmacokinetic interactions led to higher risks of osteonecrosis. So in summary, we found that the rate of osteonecrosis and orthopedic toxicity was high in young adults treated on pediatric-inspired protocols that are heavy in the use of steroids and asparaginase. Patients who are younger and patients who receive pegylated formulations had a higher risk of osteonecrosis. And while this is a concern, we, having identified this risk, we look forward to understanding in even more detail the causes of these toxicity, developing interventions earlier in treatment to help mitigate these toxicities. So this is a problem that needs to be recognized and understood, with next steps being developing approaches to decreasing the rate of toxicity. Thank you for the opportunity to speak with all of you today. And with that, I'll close this talk.